Thank you so much. I'm excited about today's call. I'm so grateful for everyone on the panel today. So thank you all for being with us. But I won't take up too much time, but I just want to jump into a prayer. So will you pray with me? Holy and everlasting God, Lord, you are our help in ages past, and you are our hope in years to come. Lord, we thank you for bringing each and every one of us together this day, for we know that it is not by accident nor coincidence, but it was indeed your divine providence that has once again allowed our destinies to intertwine. Lord, we thank you for this moment and everyone who is gathered together, and we ask that you really convict us and challenge us in this moment and really show us or reveal to us in the various ways that we can really help to bend the moral arc of the universe closer towards justice. Lord, we want to be your hands and your feet in this world. And so we ask that you guide our feet as we continue to run this race. We pray this in the name of the one whose steadfast love endures forever. And all the people of God said, amen.
Amen. Thank you, Reverend. Yes.
Oh,
So,
amen.
George, would you
Yes.
would you like to say something in regards to the African Fellowship? So to let people know what the African Fellowship is, as well as Riverside Church.
Yes, indeed, of course. Again, I want to just welcome everybody on behalf of the African Fellowship Committee. We are, as Ms. Yemi said, we are our moderator. The African Fellowship Committee is part of the Riverside Church and a bigger part of New York City and the state and even the world, because we do attract everybody everywhere in the world, black, white, pink, all of us. We are all in together. And so I want to welcome you guys again on behalf of the African Fellowship and also the Riverside Church at large. Today's program, we're going to be having interesting things, especially with the world, where what we are experiencing now, not just here, but all over the world. This morning, I was talking to people in Africa. They were telling us that they started going to church. They're going for 90 minutes. They sit at a distance 12 feet apart. All of this pandemic has caused so much disruption all over the world. This is something that we have to live with. Europe now, everything is going up. We thought it was getting better. Here, they say another 47 states is all the way up. So this is very, very, very important for these type of forums to come in where we put in place here. Everything we do is try and error, but hopefully at the end of the day, we're getting more information than less. So I just want to say on behalf of the African Fellowship and also the Riverside Church, I invite all of you with all the talent. I was listening to the panelists. We do have the best of the best. And I'm glad that we are all here. Before we start, let me just say something about the moderator today, Miss Yemi Ayola. She's a young, ambitious young lady, very, very talented, very, very smart. I've always admired her. And I think today she's going to do a hell of a job. Let me just say a few of just one or two of our experiences that I have known for her. She's an associate director of Patient and Public Safety Office at the NYU Health and Hospital Corporation. And she is also a director of at large at the New York Association for Healthcare Quality. And also, she also is an analyst for the quality of care and improvement at Columbia Presbyterian Hospital. So these are just some of the activities that she's been involved in the last couple of years. We do know she's going to provide us a very good administrative protocol today as we go through the panels. And I'm really, really, really excited to be a part of that. Without any ado and holding off here, I'll pass you on to Yemi, our moderator. Welcome.
Thank you. Thank you for the kind words from our chair of the African Fellowship, George. So I would like to welcome you to this segment on COVID-19 and public health and its effect of those of African descent on the continent and within the diaspora. This segment is a part of a 4-part series that looks at various topics and issues regarding the pandemic. It begins today. Other topics areas that we will address are the gendered effects of COVID-19, which is next Sunday at the same time, the politics of COVID-19, which is on November 1st, and COVID-19 and the survival and the vitality of the Black church. So please check out those segments as well. Today, it is my pleasure to introduce you to our distinguished panelists who will help guide us in our understanding of the effects of COVID-19 among health-wise among populations in the Africa, on the continent and in the diaspora. Okay. Our panelists include Dr. Patricia Fernandez da Silva, who is, PhD, who is the lead of the United Nations Population Fund strategy to advance the health and rights of people of African descent. We also have Dr. Joy St. John, who MSMB and MPH, who is the Executive Director of the Caribbean Public Health Agency. And last but not least, we have Dr. and Esquire Jonathan Perez, who is the founder of Justiceology by Design. So that we know more about the expertise that our panelists bring. Okay. I'll tell you a little bit more about Dr. Patricia Fernandez da Silva. She leads, as stated before, she leads the United Nations Population Fund's global strategy to advance access to quality health and the rights for people of African descent, under the Agenda 2030 principle of leaving no one behind, and in support of the implementation of the program of activities of the International Decade for People of African Descent. Dr. Fernandez da Silva provides expertise on the implementation of the UNFPA's programmatic and advocacy strategies using a human rights approach. Dr. Fernandez da Silva joined the UNFPA in 2019. She brought with her over 15 years of experience working on gender equality and women's rights and human rights. Prior to UNFPA, Dr. Fernandez also served as the Associate Director of the International Planned Parenthood Federation, the United Nations Liaison Office in New York, and as the Gender and Health Advisor for the mission of the Republic of Angola to the United Nations. Born in Luanda, Angola, Dr. Fernandez da Silva has conducted research on applying a gender perspective to HIV/AIDS prevention in Luanda, Angola. As the Communications and Research Director of Population Services International in Angola, she developed the first private sector workplace HIV prevention program in Luanda, which eventually scaled up to the national level. She has worked with international NGOs in Africa, Latin America, and in the United States, implementing life-saving sexual and reproductive health programs, and successfully advocated for gender equality and women's empowerment in health policies. Dr. Fernandez da Silva holds a master's degree from NYU, Wagner's Graduate School of Public Service and Public Administration, with a focus on public nonprofit management and policy, and she has a PhD from Tilburg University in sociology with a focus on gender. Welcome, Dr. Fernandez da Silva. Okay, our next panelist is Dr. Joy St. John. Dr. Joy St. John is dedicated and reliable with a track record of achievement in public health systems management and development and health diplomacy. Her firm, but Fair Style, has assured her place in networks of practice across the world. Dr. St. John has been the Executive Director of the Caribbean Public Health Agency, also known as CARPA, since July 2019. As the Executive Director, she provides leadership and direction to CARPA in executing the functions laid out in the CARICOM Intergovernmental Agreement. Along with the CARPA team, Dr. St. John has led the public health response to the COVID-19 pandemic in the CARICOM region. As Assistant Director General of the World Health Organization from October 2017 to April 2019, Dr. St. John had direct responsibility at the World Health Organization for climate and other determinants of health. And she is the first Barbadian, and you have to correct me in regards to my pronunciation, but she's the first Barbadian to be the Assistant Director General. As a former Chief Medical Officer of Barbados, she was the the first Barbadian to hold that office for over 12 years. She was the top public health advisor to the Minister of Health and responsible for the oversight of the management of the health sector. Dr. St. John was also the chairman of the executive board of the World Health Organization from 2012 to 2013. She was the first Caribbean person to hold the position. Dr. St. John holds an MBBS and MPH from the University of the West Indies. Welcome, Dr. St. John. And last but not least of our panelists is Jonathan Perez, PhD in Esquire. He is the founder of Justiceology by Design. Jonathan is a racial justice advocate and a professor at Wesleyan University in structural inequality and critical race theory. Previously, Jonathan was a senior assistant district attorney in New York, where he worked on many social justice policy initiatives over the past 4 years. Jonathan was promoted to senior assistant district attorney after starting the first ever research manual of Brooklyn's history of structural racism and systemic inequality from slavery to the New Deal. As a senior assistant DA, Jonathan trained young prosecutors on the communities they served and ensured just prosecution and fairness for all. Additionally, Jonathan recently gave a 2-day seminar at the New York City Bar on criminal justice reform. Jonathan has been involved in law, policy, and critical race theory for nearly a decade. Early in his career, Jonathan served as an adjunct professor at Hunter College in New York, and he taught New York City private schools such as Lassie Francas de New York and Prep for Prep, a leadership development program that offers promising students from communities of color access to private school education. Jonathan has won prestigious civil rights fellowships, including a SPARA fellowship supporting his work at the leading Latino rights organization, the Mexican American Legal Defense and Educational Fund in Washington, D.C., where he also served on the Congressional Hispanic Caucus. Jonathan is the founder of a racial justice and equity training program, Justiceology by Design, which focuses traditional equity, inclusion, and diversity programs that localizes participants with anti-racist readings and workshops, and which also teaches the U.S. histories of laws and policies that produce structural inequality. Jonathan is also a published author and poet and has a book titled The Cartographer of Crumbled Maps, A History of Racial Injustice in Poems. Welcome, Jonathan. So our program for today is that each panelist will give an overview of what we should know regarding the effects of COVID-19 on those of African descent within their respective areas of the African continent, the United States, the Caribbean, and Latin America. Afterwards, there'll be a moderated Q&A between myself and the panelists. And last, the discussion will open for Q&A to guests, to yourself, to attendees. To begin, Dr. Fernandez de Silva, Patricia, will give an overview of how COVID-19 affected people of African descent in Africa and Latin America.
Thank you, Yemi. Thank you for the great introduction, and it's good to be here in such good company. So good afternoon, and it's an honor for me to be here today with you. Like it was just said, my name is Patricia da Silva, and I work for the United Nations Population Fund. So UNFPA is represented in over 150 countries and is a world-leading sexual and reproductive health agency working on increased access to sexual and reproductive health services, promotion of gender equality, and women's empowerment and prevention of sexual and gender-based violence. Over the past 25 years, it has developed strong thought leadership and a unique set of proficiencies that support the advancement of rights for the most vulnerable, the most marginalized, and discriminated. And that really is one of the reasons why I'm here with you today. So COVID has paralyzed cities and countries, and it continues to spread around the world. we have learned over the past few months that the virus is not an equalizer. It continues to draw lines along social and economic divides when it comes to nations and individuals' ability to prevent contagion, ability for governments to provide testing and access to quality health care, as well as ability to governments and individuals to stay financially viable throughout and after the crisis. So generally speaking, high-income countries are better positioned to respond to crisis. However, reality showed us that even within those developed countries, there are striking inequalities in both access to quality healthcare and health outcomes for different populations and for different communities. In 1966, Dr. Martin Luther King Jr. said, "Of all forms of inequality, injustice in healthcare is the most shocking and the most inhumane." And these words never rang truer to me than right now. Several studies have shown that a combination of health disparities, discrimination, and structural barriers that include unreliable or no access at all to quality healthcare services makes communities of color, including people of African descent, certain migrant communities, and low-income communities more likely to be uninsured, and also to have a history of poor health outcomes, such as higher rates of heart disease, diabetes, hypertension, asthma, and other chronic conditions. That's even after we account for other health determinants. So these communities are also more likely to hold essential jobs, jobs in healthcare, social care, jobs in retail, jobs in public transportation, manufacturing, hospitality, and other sectors. Sectors, though, that are unsuitable for virtual working arrangements, and sometimes even social distancing. So this combination of factors puts them on the front line and at the risk of exposure to COVID-19, but also makes them more vulnerable to the virus itself. We are observing that these are the populations most affected and infected by the virus. So the localized epidemiology of the COVID-19 pandemic, meaning the high numbers, concentrated numbers of COVID cases in those specific communities, is a clear indication of the correlation, the link between the racial and socioeconomic status of these populations. Latin America and the Caribbean is home to the largest population of African descent, with around 130 million people, more or less, identifying as people of African descent. It's also one of the most socially and economically unequal, and where internal social and economic inequalities faced by racial and ethnic minorities are systemic and they are persistent. The region also now is currently facing slow economic growth, which has been made worse by the COVID-19 health and economic crisis. In the region, people of African descent, Latin America more specifically, people of African descent often live in poverty. This manifests itself with limited investment in Afro-descendant communities and structural barriers for access to quality health care services. The region is also now the new epicenter of the COVID-19 pandemic, accounting for approximately 10,211,000 cases of new infections, as well as about 373,346 deaths. So the pandemic has exacerbated, highlighted, and deepened severe racial, social, and economic disparities. We know observational evidence has shown that people of African descent are the hardest hit. They are being infected in higher numbers. They are dying in higher numbers. They are suffering disproportionate social and economic effects. Discrimination and unequal access to healthcare and medical supplies makes it difficult for Afro-descendant people to gain access to COVID-19 tests and hospitalization and treatment. Furthermore, the pandemic has also affected essential healthcare services, including, very important for UNFPA, access to sexual and reproductive health in several countries in the region. So Afro-descendant women may face limitations in accessing prenatal care, consultations, and childbearing care. This is under a context where they are already 2 to 3 times more likely to die of preventable maternal causes. So COVID will only make this already serious situation worse. There has also been an interruption in the supply of contraceptive methods, and that's also very dangerous. Like in many other parts of the world, gender-based violence has risen. We are witnessing challenges in access to clinical management of sexual violence, prevention, and other mitigation services, as well as challenges in the use of shelters where they are available for the obvious reasons: quarantine, distancing, and the need to isolate. Now, the reported numbers in Africa are actually comparatively quite smaller. Approximately 1,250,000 infections and about 28,000 deaths. In fact, according to the World Health Organization, Africa has one of the lowest rates of infection and accounts for only 3% of the new deaths reported globally just now in October. So scientists really have not reached a consensus as to why this is the case. There are theories, including potentially cross-immunity from other coronaviruses that have come before. Also, COVID-19 is known to have a higher mortality rate for older age groups, and Africa, as you may know, has a relatively young population, so more than 60% of the population is under the age of 25. So it's very young. However, a concern in the region has been the rate of infection of healthcare workers. And this is very concerning because health services are disrupted when health workers have to go into self-isolation or quarantine for prolonged periods of time. Also in the region, the health infrastructure is generally speaking underdeveloped. And so this could become a serious concern should the numbers continue to grow or even to start growing a bit faster. Another concern to highlight for the region is that existing social and economic inequalities are worsened by the lockdown. So social and economic consequences of the pandemic can be very serious and they can be very long lasting. So containment and other public health measures such as regular hand washing, social distancing, virtual learning, etc., really in the region, they cause very practical and equity and equality concerns, right? Because not everyone has access to those kinds of services. And then because a large percentage of the population is employed in the informal sector, so without the ability to work remotely and is often dependent on daily markets, the effects of the mandatory quarantines really can have serious financial consequences for families and communities. In fact, the United Nations Development Program Agency has estimated that nearly half, and I'm going to say this again, nearly half of all the jobs in Africa could be lost due to the pandemic. And I cannot tell, I don't have to tell you how serious this could be. Here too, gender-based violence has been a big concern. It has considerably escalated in the region, and this is demonstrated by the increased reporting through self-help lines and other safe spaces. It is a particular concern for those women in poor communities and with limited options. There has been also reported disruption of menstrual hygiene management in areas with limited access to water, sanitation, and hygiene products for adolescent girls and young women. Another issue that young women and girls are also facing in the region is female genital mutilation and child marriage. Before the COVID-19 crisis, an estimated 3 million girls were at risk of undergoing female genital mutilation every year. We fear that this number has significantly increased due to the disruption on the prevention services and other community-based interventions that we were implementing in the region. COVID-19 will also disrupt efforts to end child marriage, potentially resulting in an additional 13 million child marriages taking place between now and 2030. And they could otherwise have been avoided. So the COVID-19 crisis really exacerbated the problem and the concern with child marriages. So UNFPA is responding to these challenges though. Our global response in countries across the globe supports preparedness, response, and early recovery with the goal of obviously saving lives and building communities better. And it focuses on 3 main strategic points. So we focus on continuity of sexual and reproductive health services and interventions, including protection of the health workforce. And I'm talking about your midwives, your nurses, your LBGYNs. Point 2 would be addressing gender-based violence. So continuation of those services that are necessary to protect women that are victims. And 3, ensuring the supply of modern contraceptives and other reproductive health commodities. And we talked a little bit about, the menstrual hygiene and some other issues that we are looking to continue those services. The measures also include supporting community-based mentors, women and youth groups in tracking and supporting girls that are at heightened risk of both female genital mutilation and child marriage due to the COVID-19 crisis. And under the leadership of our executive director, Dr. Natalia Canham, we are also firmly and unequivocally committed to continue to support the work to bring equality for people of African descent, including in the context of our global response to COVID-19. In fact, our response plan specifically includes a focus on the most marginalized and discriminated. And where they are represented, in those regions where they are represented, we focus our response, our efforts on communities of African descent, indigenous communities, and other marginalized groups. Dear friends, we all know the inequalities faced by communities of color, particularly people of African descent, they did not arrive with COVID-19. They were already here. They have always been here. They are caused by centuries of discrimination and structural racism. So it should not be a surprise to anyone that COVID-19 has highlighted the divide in a world that is already so afflicted by severe racial, social, and economic disparities. At UNFPA, we continue to work to build back better and to bring us closer to justice and to equality. And I will just conclude, if you allow me, by remembering Nelson Mandela's words. As long as poverty, injustice, and gross inequality persists in our world, none of us can truly rest. I thank you.
Thank you, Patricia. Thank you for the presentation. Next, Dr. St. John will give an overview of the COVID-19 response in the Caribbean, the public health response in the Caribbean.
Thank you very much for this opportunity. And I just need to find out if you can see my presentation, if it is in slideshow.
We can see.
Okay, so I am presenting on behalf of the Caribbean Public Health Agency. And I'm going to be presenting on COVID-19 and public health. And this is what I hope to achieve in my 15 minutes. A brief overview of who we are and who we serve, CARFA's role, governance of the CARICOM COVID-19 response, the impact of COVID-19 on the CARICOM region, the challenges and the solutions that we have put in place, a little bit about the CARICOM bubble, and you'll hear what that is when I get there, what comes next, and my conclusion. So CARFA is very young, only 7 years old, and headquartered in Trinidad and Tobago with campuses in St. Lucia and Jamaica. And we're the amalgamation of 5 regional health institutions. And so we have an unusual makeup for a public health agency with expertise, not just in usual surveillance, but also in environmental health and environmental management, in drug quality control, including testing, and the environmental health. There's also a lab, and all of our labs are accredited. We have also expertise in nutrition and research. And at the headquarters, there's a Caribbean Medical Microbiology Lab, which has been doing all of the testing for COVID-19. We were formed in 2011, and we have an intergovernmental agreement with 26 member states, and I'll show you these soon. Our vision is healthy people, healthy spaces, healthy Caribbean, and this is who we serve. And you will see that there are several countries that are also overseas territories of UK and also of the Netherlands. So we have English speaking, we have Dutch speaking, we have French speaking in Haiti, and we have Spanish speaking in Belize. So I wanted to give you a little bit of understanding of the determinants of health in the Caribbean. One is climate change, but that's a determinant of health everywhere, like it or not. The other is this whole issue of globalization. And as we import a lot of our food, and we are heavily influenced by global trends, you can see how this would be a noticeable determinant of health. And then something which also has an impact on COVID-19, an enormous burden, one of the greatest burdens of chronic diseases and risk factors in the world. And then we are economically dependent on tourism and travel for the main part. The epidemiological profile shows that 7 of the countries in the region have mortality rates above 583 per 100,000. And we have exhibited some of the highest NCD mortality rates in the Americas region, with more than 70% of deaths in the CARICOM member states being due to NCDs. So what is the health system that manages all of this? Well, we have a very heavy reliance on primary health care. It's a strong pillar of health, and the primary health care is both delivered in the public and private sector. But in the public sector, there is a strong public health management structure. And because we're small countries, the ministries of health, with some countries, larger countries like Jamaica and Trinidad having regions, but the Ministry of Health usually controls the management. And this has worked very well in the COVID-19 response because we've had a centralized decision-making, which for the most part, as I will show you coming up, has been very strongly linked to the decision-making of the heads of government. Our response has not been separately funded for the most part. And so we've drawn resources, both human, financial, and material from other programs. And I focus again on NCD programming because it was under-resourced before. It's unfortunate that there is therefore such a heavy burden. And then, of course, persons with NCDs of any age are more at risk of developing the severe and critical forms of COVID-19. So what was CARICOM's role in this whole thing? Separate and apart from our usual role, our role was resource mobilization, risk communication, because we had an infodemic of fake news as well. Provision of advice to non-health sectors and coordination of the public health response. So I'm giving you a glimpse into what we did. And we did this from the perspective of health security. And we actually started in November, not knowing about COVID-19, but we placed epidemics on a higher tier of the 4-tier risks and threats table. And then we have used the security cluster, which includes the regional security system, the Caribbean Disaster Management Agency, impacts, JRCC, which helped us track people coming from countries of interest into the Caribbean, and a heavy involvement of the different security sectors. If you look on this timeline, we've interacted with prison chiefs, chiefs of immigration and customs, the police, and of course, the ministers with responsibility for national security, many of whom are in charge of a large aspect of the national management. But the governance and leadership has most definitely been under the control of the heads of government. And you see the bottom left, the current chair of conference of the heads of government of CARICOM, the Honorable Ralph Gonsalves, Prime Minister of St. Vincent and the Grenadines. And they mandated common public health protocols, most recently the CARICOM travel bubble, involvement of all sectors. There has also been a very critical technical interplay between the chief medical officers. CARFA hosts a WhatsApp group and they talk to each other, they advise each other, they share tips, they share information. And of course, the ministers of health also have that facility. And the role of the CARICOM Secretariat at bringing all of this, especially the multiple sectors, has been critical. So this gives you a timeline of what CARFA has been doing. The bottom left shows you some of our products over time. So you notice that we started way before we got cases. But I also want you to notice that our cases are increasing and the rate of increase has been increasing as well. So this is due in large part to the fact that we are trying to get back to economic activity and opening our borders to tourism and travel. And what I show you here on purpose does not have the names of the countries, but it shows the epidemic curves, the same countries on left and right. One before the lockdown, because the CARICOM countries locked down all as a group. So it's like a choreography, and now they're opening up the protocols in place. And you'll see that the CARICOM region has not finished its first wave. And for most of the countries, there's only been a slight blip. Well, there's some countries that are having issues. And I will show you later how the transmission of cases is going. But the return to economic activity has caused some of the blips, but they're still at present time for most of the countries manageable. So we've got 3 types of transmission: community transmission in only 8 member states, clusters of cases in 6, and sporadic cases, and indeed some with no cases. And this is all very important for the CARICOM bubble, and I will tell you more later. But we've done all of this, but there have been challenges. And in the previous presentation, we also had a lot of the same challenges. but we decided that we were going to address them. So the same issues with access, the same issue with under-resourced systems and therefore surveillance not being optimal. The fact that we are so tourism dependent means that we had massive economic shocks. We have tried our best not to get rid of most of the government jobs because in our territories, most persons are employed, or each family has one person employed by government, but private sector jobs have been lost. And of course, it is not easy coordinating multiple sectors. And these are the ways in which we address the challenges. CARFA came up with a new regional integrated surveillance strategy. And we are trying to ensure that information flows in both ways so that the member states are advised of what is happening. Our sector, our main sector, tourism, CARFA formed a COVID-19 tourism task force with the Caribbean Hotel and Tourism Association, the Caribbean Tourism Organization, the Organization of Eastern Caribbean States, and the Global Monitoring Consortium. And these are some of the factors that we put in place: developing protocols, training, over 5,000 people have been reached, advanced food safety and hygiene certification, the Caribbean Travel Health Assurance Stamp for healthier, safer facilities, and of course, voluntary self-reporting on the Tourism Health Information System and also with an app. Collaborating with multiple sectors, a lot of this has been achieved through the role of the CARICOM Secretariat in convening sectors and also allowing us to develop protocols which have a health focus so that there is a safe return to activity. And then, of course, the role of the heads of government with an all of society approach at the national level and demanding coordination of certain regional protocols so that there is a sameness in the way in which we return to safe lives. This procurement issue, we could not get access in some cases, not because we may not have had money, although that has been an issue in some cases, but even when we had money, we had some of our purchases seized. And so to overcome this access issue, a procurement and distribution hub was located in Sedema, and in the center, that imposing lady in rust-colored pantsuit was the chairman of the Conference of Heads, the Honorable Mia Mottley, Prime Minister of Barbados, and she worked with Dr. Tedros from WHO, who organized a donation from Jack Ma. And this lovely aircraft here belongs to the Canadian government. They brought this donation to be distributed. And then we have also got access to the African Medical Supplies Platform. And then we have done some specific things. Yemi told me I should say some of what we've spoken about. We've actually had 100 situation reports and counting. So we developed the situation reports so member states knew what was going on. We developed protocols and guidelines and did infographics so that we simplified and demystified the information. And of course, we've now started training so that the center picture shows one of our COVID-19 health rounds, the last one, which was held last week. And so we've been trying to go through a process. Our last process would be research. And then, of course, something I'm very proud of, this happened on Friday. When I told you about resource mobilization, CARFA has done resource mobilization, and part of that has been through the European Union. And they gave us a pot of money for supporting the purchase of vaccines and treatments. And so we had a partnership with EU and PAHO which is going to be the interlocutor for the COVAX facility in this region of the Americas. And we were able to support more than 1 million doses of vaccine through giving countries, member states, the down payment. So they don't have to search for that money because we're all suffering. So we're quite proud of being able to cover the down payment, 100% of the down payment for so many of our member states. So the CARICOM bubble, apart from having the vaccines so that people are protected, we are also having the CARICOM bubble. Countries which meet the criteria of no cases or low risk can have travel among them and with no testing and no quarantine. Of course, there are other requirements if you are not a CARICOM country in the bubble, or if you're outside of the CARICOM region and you want to travel in. So what comes next for CARICOM? So we have to ensure the convening power for policy decisions. And I'm talking not just sectoral, but national and regional. Continue to ensure processes are in place to respond to any disaster. Right now, we're in the hurricane season. We've been lucky so far, but we're also in the vector season and we're having outbreaks of dengue. So we're working on that as well. Maintain partnerships on health system strengthening, ensure health security is maintained, and ensure resource mobilization is available and accessible to CARICOM. So in conclusion, due to the NCD burden to the region, we are at risk for severe critical disease and death. So we have opted to prevent importation and illness. CARICOM governments have committed to a collaborative approach. Health systems and sectors are better prepared to return to life with COVID, even with vaccines. Not everybody will get a vaccine, so we have to find a way to live. And the CARICOM member states, with the support of EU, PAHO, and CARPHA, have committed to vaccine procurement. Thank you for this opportunity.
Thank you, Dr. Joy. Our next presenter is Dr. Jonathan Esquire. He's going to give an overview as to why those of African descent in the United States were disproportionately impacted by COVID-19.
Thank you, and thank you, everybody, Yemi, and those wonderful presentations. I just wanted to give a kind of an introduction to, who I am and kind of how I'm approaching certain words here. In particular, structural racism, structural inequity, and then versus kind of systemic issues. So one thing I was going to do, but I think we're all on mute, is does anybody know about the word itself? So structural racism, in terms of who it is that kind of first coined that term. The reason I mention it is because I was, surprised when I looked it up. I'm sure someone here knows. It's Stokely Carmichael. When he was doing his academic kind of curricular shifts in the early Black Panther movement. I'm going to give now a story. So the macro level of what the health effects are of structural inequity are very clear. I think a lot of people have seen in the news, the statistics. As someone who was involved in health and safety for criminal justice reform, I realized, and I actually stopped my job because I realized that we're not really approaching structural equity in the same way that we approach things like individual anti-racism. And so that's one of the reasons I started my group. And what I mean by that is, for example, America intends to be the living embodiment of democracy. So there was a great show. I don't love Paul Giamatti, but he played John Adams, John Adams. And he said, liberty cannot be preserved without a general knowledge among the people. However, COVID-19, to me at least, has shaken the foundations of our democracy to its core. One of the reasons it has is because law, to me, like civil rights law, individual liberty laws, Brown versus Board of Education laws, do not address structural inequity. So what do I mean by that? It's my, one of the articles that I recently have in a law review today is on the difference between looting and rioting, and then the voices of the unheard, which Martin Luther King once said, and his grandson actually went through it today. I want to kind of show you this slide I have about some of the differences between inequity and equity. And my parents were civil rights activists. I have every intent to believe that equality is, obviously very important, but that is not the place we're in today. So for example, the civil rights movement, the dominant narrative was individual equality. Let's say we're talking about women's rights. The Fair Housing Act protects against discrimination based on race, gender, ethnicity. Voting rights, and Brian Stevenson talks, these are all individual rights. And what I'm saying right now is that I honestly believe today the most important thing is not so much equality as equity. So large scale prosecution, mass incarceration, and mass policing affect equity and structural equity. COVID-19 has moved the veil in a way on large scale inability to access quality healthcare. From that, we have protest movements today among the young and old, multiracial, generational movements of Black Lives Matter, Occupy Wall Street, and Standing Rock. America itself is dominated by the difference between what it holds itself out to be and the systemic underlying narrative. So historically, we could look at, for example, the revolution. This is kind of the earliest I could think of. The liberty from England is what we're taught in school. Of course, the slavery and the triangle trade is the underlying narrative. The 13th Amendment ended slavery. It allowed the Great Migration ultimately, and it allowed many people to move north. However, in Brooklyn, and what I like about kind of my study that I present on is that I don't forget the North. In Brooklyn in particular, the segregating effects of things like public housing, even little policies of municipal sanitation removal, and I'll show you that in a second, continue a segregating effect that has a direct relation to health. So, when we're taught in school about freedom, we have to remember that there are policies that still have a disparate impact. I don't want to spend too long on the numbers, but I think they are very stark. For those of you who know Arundhati Roy, she's great. She wrote an article at the very beginning of the pandemic. I think it was in May. She wrote that historically pandemics in general have forced human beings to break with the past and imagine the world new. This one is no different. It's a portal between this one and the next. However, she spoke about India and how the pandemic had a wreckage on the poor and vulnerable, similar to what is happening to the US. At the very beginning, it's still happening. States were forced to bid against one another for ventilators, overwhelmed hospitals, of course, underpaid, overworked nurses. And there were videos online of patient dumping, meaning that sick people, one of which was my dad, were turned away by hospitals. The goal in the beginning was this quote, flattening the curve. I don't believe that that affects structural inequity. Flattening the curve is a phrase that risks death to a number of people who are kind of not on that quote unquote curve. In a very real sense, the numbers outside of New York first are pretty stark, and I guess I'll address the US. Louisiana in particular was one of the hardest hit among the people of African descent and Black American population. 70% of those who had passed were of African descent in Louisiana. However, they only comprised 33% of the entire population of Louisiana. Michigan, African Americans made up 14%, but comprised 40% of the deaths, and the numbers go on. The Poor People's Campaign in particular had a really good article about this, saying why is this the case? There's a history of voting local politicians into places of power, especially in the South, but also now in New York, that tends to think of less government, this idea, this movement of less government. That in effect creates a gap in the safety net. So these states in particular have no public services and public welfare. This is not something that's limited to the states. I just want to show New York just very quickly, and I think everyone knows this. In New York, this is a month old, but this is from the New York City Health Department. Again, Hispanic, Latinx, Black African people of descent predominated the population of fatal and non-fatal, also non-fatal cases. There is a sense that we need to heal, right? So let's say, especially in Brooklyn, which is just where I am right now, we have a certain effect, ripple effect of this virus that isn't just the virus. Now, I'm not downplaying the virus, right? But the ripple effect among the communities that have been, realized now, this history of disproportionality, like in a real sense, is now being internalized, right? There's a sense that the narrative of the US, which we kind of knew, growing up, you kind of knew, you watched the shows, you hear, even during the civil rights movement, we didn't have this sense that there's a complete abandonment. And there has to be a healing that's happening. And I don't believe it's finished in terms of the healing. That healing, to me at least, and now I'll relate my story, has to do with how we talk about ourselves and how we talk about race. So for example, I'm in a room, so I'm no longer a prosecutor. I'll be very honest, I actually stopped being a prosecutor after I saw the George Floyd video, mostly because my dad was homeless growing up and he had been touched in a very real sense by the state and by police. And I couldn't identify myself with a system that does that. However, I'm in a room and someone comes in with a pin, right? People wear pins. The pin says Blue Lives Matter, right? Blue Lives Matter, right? At my position, I had many friends who were community policing, they were police. However, structural racism means that if right after George Floyd, or even to some extent Breonna Taylor, we have a pin on, it produces a microaggression. It doesn't affect healing. This is not the time to say things like that. And people are not recognizing it as, quote unquote, racial bias. They're just saying, oh, I just want to wear that pin. It's not helping the healing, right? And so what I did is I wrote these articles that talk about structural racism, and not just individual race, but structural inequity. What is the cost of racism? So people, I'm sure a lot of people on the call know this in terms of when I talk to some people, they say, oh yeah, I can't afford to help other people, this kind of pseudo independence. The pizza pie, that if we help different parts of the population, my slice is gone. That is absolutely not true. This is now it's actually 5 days old. Citigroup is a large bank. They released a study saying that if the racial gap of banking and housing had closed over the last, let's say 100 years, we would be able to add $1 trillion of gross domestic product every year for the next 5 years. So in a very real sense, structural racism is actually costing the US in gross domestic product. So it's not something that is just morally driven, but it's actually a real American economic issue. I just wanted to, this is just a slide I have, why I started my program. I'm a professor, I'm a lawyer, I'm a this and that, but I wanted to start a program that moved from our traditional ideas of white supremacy and racism, right? So they could be explicit, implicit, to also understand structural inequity and structural racism. So as everyone knows, there's residential issues, right? There's healthcare, quality healthcare, which we're talking about today. There's anti-literacy laws that have a lineage from post-Jim Crow to today in the school to prison pipe. There's an educational lineage. And of course, there's criminal justice. I just said this, I was surprised about it. There's a need to examine mindfully structural racism. So for example, what I do in my course is I present an issue such as, let's say, the Upper West Side. Riverside Church is not really, is it? It's kind of the Upper West Side, right? Okay, maybe. So Upper West Side, yeah. So Upper West Side, I do a workshop with participants and I say, there's an increase in homelessness and panhandling, which again, I know very personally because my father was in and out of that position, and the local community board, right, wants to increase the sentencing of panhandling to make it a felony offense, like a harsher offense, right? And then I say, is that just, right? Like, is that something that we should do? And, students will say, yes, we don't want the health effects of it. Maybe they're not wearing a mask, all this kind of pathologizing, which happens all the time to Latinx people in Black America, which is the retributive approach of law and justice. Is there a restorative approach? Is there a way we can have, a reintegration and an amends where the whole community can repair the harm by actually seeing people as people? Perhaps they've been driven out by gentrification. Perhaps you need to learn about where you live, right? Like the very block we live on. And this is the perfect time to do this work. I'll give you an example. My wife, who just left the room, so I can talk about her, I'm just joking. She's a lawyer. And there was, during the protest movement, Instagram, right? People post a black screen in solidarity and affinity with the Black Lives Matter, right? You post the black screen. There's someone in her office that posts a white, like an all white screen, right? And then the head of this office, right, says, could you please stop? Could you please take this down? I don't understand. And she says, no, I'm going to leave the white, the white screen. And then she's fired. Okay. This example, I know it sounds like far-fetched, but this example is occurring all over the country, which is to say that just firing this person for that community, like whoever sits in the cubicle next to the person, whoever's in the household with the person, the issue's pushed under the rug. Who knows how many, quote unquote screens, like people didn't actually do it, but still feel that way, exist. And this is not affecting the true healing we need right now. And so what I'm trying to do here is to develop a mindful kind of racial justice literacy. The last thing I will say is I want to just turn to a different restorative approach, which is Angela Davis's quote, which I actually love. This idea that, when we recognize that when Black Lives Matter, whenever that happens in history, that will mean that all lives matter. So this is what Dr. King called the indivisibility of justice. And I like the word that visibility is an indivisibility, and I like the fact that it puts it in that context. To me, this is a very meaningful quote because I'm from a Latinx community, and I guess I'll end with this, but I have a lot more. Because Latinx people, I was once given a job of creating a national Hispanic prosecutors, and that was the hardest job I've ever done. Why? Because Latinx people from Cuba who live in Florida are diametrically different than Latinx people who are Chicana who live in California. They don't speak the same language even, they have different perspectives, right? However, when we have ICE deportation, when we have mass disparate impact of health, they come together, right? So during moments of racial crisis, that is when collectivity comes together. And that is very important because I think more than ever, that collectivity, even if we're from, I experienced the Castro regime and I moved to Florida, whatever your background is, you see on TV the justified anger of Black and brown communities. And that I can't drive home that enough for healing. And that is actually, sorry, this was kind of so theoretical, but that's actually the purpose of why I left my job to talk about systemic issues and to try to affect healing. I'll be around to answer any questions, but I wanted to leave with a kind of positive note. And thank you.
Thank you, Jonathan, for your presentation. So that will conclude the first half of our segment, which is the presentation. Now we're moving to the second half, which is the Q&A between me, the moderator, and our panelists. The first question goes to you, Jonathan, and it's based upon the article that, as well as your presentation, the article that we sent out to attendees. Is systemic racism by design?
Yeah, I like that question. And I remember you asked me this in a run through. The truth is, so I'm a lawyer and a legal scholar. And to the extent that, let's take affirmative action as an example, right? Ta-Nehisi Coates has a wonderful article, I'm sure everyone's read it, but it's on reparations in the Atlantic. I use it every day. It's a wonderful article. But there's a quote in that article says, if diversity is to help Black America, it isn't enough. If affirmative action and diversity is to help Black and brown communities, it isn't enough. Because of the specific legal history of redlining, and I had a great image of redlining, the history of laws that are unarticulated. So Bedford-Stuyvesant, where I live, there's a great professor called Brian Purnell that talks about this. The Congress and Racial Equality was like a wonderful, early community organizing group, right, in Brooklyn. They had a municipal law that said, we'll pick up the sanitation twice a week. Okay, doesn't sound like a big deal. Marine Park, it's Italian. Marine Park, a white neighborhood next door, right next door. They pick up sanitation 5 times a week. Okay, so the Congress and Racial Equality went to the head of New York City sanitation and said, could you please, why is this the case? He kicked it back to them and said, it's a human element. And so if you read between the lines, it's saying that it's your fault. It's littering. After a 3rd trial, they finally got it to the place of it's actually picked up more now than Marine Park. The reason I'm bringing that up, though, is when we talk about design, the laws don't have to say in their language, I am being structurally inequitable, but it could be something that no one knows. It's very little language, and we all have to be conscious to see it. And I think it is by design, but this is the moment to be hopeful, and we could all come together to change it.
Okay. Thank you, Jonathan. My next question is for Dr. Joy. In regards to the Caribbean, the CARICOM region, is within the health data that's collected, is race an element of the data that's collected so that health disparities can be seen and obtained?
So not normally is race collected, and we look at the issues of race in the Caribbean not only from the position of color. We also have indigenous peoples in the Caribbean, descendants of Caribs, mainly in some of the Caribbean countries. And also we're starting to look at things like persons who immigrate, because we started to see COVID immigration. Persons immigrate from other countries, mainly to our south, and coming into the Caribbean to live because it is relatively COVID-free. So we really haven't been looking at race. Our health system isn't normally set up to cause disparity in delivery. And perhaps that is part of the reason why I focus on primary health care and public health, because there is the effort to have access, no matter what your color or your social standing. And so the effort to have that, and especially from the preventive perspective, perhaps has minimized our issues with disparity. The other thing is that in the Caribbean, our governments are usually, for those that are not overseas territories, our governments are usually run by persons of color. And so it is not usual that persons of color will discriminate against themselves. So we have not been detecting that that has been an issue. We have some countries that have a heavy Black and Indian mix. And we've been looking at that to see if there are any issues with disparity in access. And that has not come up yet as an issue of concern. We are watching it though.
Okay. As a follow-up question to that, is there a social construct of race within the Caribbean in regards to is those of one race or another looked at as being higher or lower class? And does that affect their health outcome?
No, it's not so much race. It is more the issue what money you have. And so you may have a two-tiered system because you can afford private sector care or you can afford to travel out of the Caribbean. But with that, the governments, especially for the smaller countries, the governments have tried to improve access. I spoke about the Organization of Eastern Caribbean States. They function as a microcosm within CARICOM, and they have tried to improve access even to cancer treatment so that most people, even if they don't have money, have access. I'm not saying it's perfect. It definitely is not. But when you have such small societies, when you try to have a system that affects some, you're going to end up affecting all. So this whole issue of access is more from the perspective of who has money, especially for very specialized care, and then you will get it faster. Not that you won't get it in the public system, but you get it faster in the private system.
Okay. Well, thank you, Dr. Joy. My next question is for Dr. Fernandez de Silva. Is the same question that I asked Dr. Joy. Within Latin America, is the racial makeup of an individual collected along with the health data so that possible disparities within health can be seen and obtained?
So the short answer is no. Data disaggregated by race or ethnicity is, generally speaking, not collected in Latin America. There are indeed, though, a handful of countries that have made some advancements in terms of collecting data that is disaggregated by race, including in some of those issues that are important, like health and education, for example. So, in fact, as part of UNFPA's mandate, we work with governments. We give technical support to strengthen their statistical commissions, or whichever is the body that is working on data, to allow them to create protocols for collecting data that is disaggregated by race and by ethnicity and whatever other disaggregation that is required. In order to really, for us to have a clear sense of what are the issues, which groups of populations are facing what challenges, because once you actually understand those pockets of populations, because you have to remember that in Latin America, so people of African descent and some other groups, they are the minorities, they're not the majority of the population. So the data allows us to create statistical visibility, of course, and it also allows these populations then to have the tools to advocate for change for those issues that they're facing, because they're armed with scientific evidence, right? They can say this is happening in our communities, and with this data, then programs can be developed to address them, policies can be developed to address those issues. And even laws be changed if need be, right? So the other issue that you have is that you also need political will and leadership that once that data is made available, it has the leadership to actually go out and implement those programs, those policies based on this evidence that was collected, which is the disaggregated data, and ensure that indeed we are tackling that lack of equity that is broadly exists in the region. But yeah, I guess the short answer is no.
Okay. Thank you, Dr. Fernandez de Silva. My next question is for Dr. Joy. One of the things that was brought up, I think, within Jonathan's presentation is the layers of burden that come together to produce the disparities that we see in healthcare outcomes, particularly for those of African descent within the United States. In the Caribbean, what will be the predominant social determinants of health that affect marginalized populations?
I think as a whole, as I would have said in my presentation, CARICOM is more affected by the commercial determinants of health. And that is seen as a microcosm of social determinants of health, where the profit margin and the quality of food and the lack of front of package labeling or front of, for food, for cigarettes would have allowed people to be put more in danger. The other determinant of health, you call it layers of burden. I remember when I first became Chief Medical Officer, we had an international consultation on non-communicable diseases, and that is how Barbados designed its program. And one of our international consultants spoke of the causes of the causes. And this is one of the things about the things that affect health are not usually under the control of the ministries of health. But apart from the commercial determinants of health, largely driven by globalization, I think another serious determinant of health are ancestral genetics. The fact that we have come out of an era where we had a lot of stunting of growth, we had a lot of malnutrition. And I think that this is something which is documented. We have had generations of children born with a predisposition for developing non-communicable diseases because they developed in utero in an environment of lack. And so we have all of these generations who are now also being bombarded with high calorie foods and predisposition for looking at life from a way of relaxing rather than exercising and moving. And so I think that is another determinant of health. It's not often spoken of, but it's something that has been documented. Research has been made available in Jamaica, for example, which is specific to the CARICOM population. That's why you see those horrible statistics about the NCD burden and the causes of death, et cetera, et cetera. So it's a combination of globalization and those genetic predispositions. Right now, we are not immune to what is happening globally in the whole issue of racial disparities, and some of the things that have been happening to our north have caused ripple effects. But even though ripple effects, the structures of our societies in the Caribbean probably largely because of the colonial overtones. The structures of our societies in the Caribbean allow us to have less demonstration in terms of crime and so on, and looting and rioting, less of that kind of demonstration of protest, and more of a demonstration of awareness of rights and demanding rights. In the Caribbean, we tend to have a little more access to our politicians. Our politicians tend to know that the voting power of their constituents is something that they should not trifle with. We've actually had several elections in this COVID year, and I think there's at least one more, if not two, planned for later this year. And therefore, the feeling of accountability towards the electorate in the Caribbean may tend to make sure that political will is on our side.
Okay, thank you, Dr. Joy. My next question is for Jonathan. You stated that, yes, systemic racism is by design within the United States, given the laws that have been implemented and the way that it's been unfairly implemented within populations. My question is, how do we go from where we are, in your view, how do we go from where we are now to where we want to be, in that there is a system of inequality and it's been created by the policies and the laws they've put in place, and how can, in a sense, what's in it for white Americans to want to actually change the way that the system is structured now? How can we go from where we are now to where we want to be?
Okay, that's a great question. I also am reading the chat, and there's some really good questions there. The first thing I would say is lexicon. Like, in a very real sense, how we talk about things builds narratives that matter. And so one reason I'm mentioning that is words like health. We should see health as pre-COVID. Opportunities when fairness, procedural justice, and structural equality, health existed a long time ago, and there were communities that had disproportionate access to health a long time before COVID. And so to create an environment, this is a quote, governments and private organizations in housing, economics, education, and healthcare should all come together and address the context of the communities they serve in a much more nuanced way. So for example, we're in a time when, these are some principles of design, but we're in a time when people say, you know, they see people on the street without masks, or everyone is kind of pretty racially charged and actually structurally inequitable in how they're speaking about things. One example is on TV, again, during, his name is Chris Cuomo, but he was on CNN, and he was talking about the way in which during the riots, right? He said nothing in the First Amendment says that we should protest politely and peacefully. And then Twitter and other people argued with him, saying that's not true. The First Amendment actually says we have a right to protest peacefully. That argument, when we're having a conversation, the shift of that narrative needs to turn to the genuine outrage of Black and brown communities, not whether or not we're defining it as looting or rioting. We're kind of missing the point. And in the same sense that we need to narrative shift, we need to understand the real experience and dignity of the moment. I think in particular, you know, there's some basic, you know, principles, but basically we all start with ourselves. No one is, you said white people, right? I've been presenting to, like, you know, organizations like the NFL, for example, and that's the same, they always ask the same question, you know, this white person from Iowa, it's always from Iowa or Indiana, you know, what, and I don't know why, but, you know, and what do they care about racial justice, racial equity? the truth is that person from Iowa and Indiana is probably more interested in it than anyone else because they don't have that kind of engagement with difference in communities. No one is from Whiteland on a map, right? Like there's no one from Whiteland. If we go to our grandparents and our great-grandparents, at some point we've all been affected by structural inequity. It could be immigration and it could be access to quality education. So to the real extent that we talk about structural inequity, this is part of everyone's story. And we have to look to make the invisible visible. Oftentimes, a lot of these issues of invisible violence, I saw the chat, people were chatting, have a lot to do with something that had been invisible for so long and now have come out. We cannot blame people for COVID. We cannot blame communities that it's their fault. We have to heal, and we have to understand that this is the perfect time to actually almost reconstruct our US. All right, that's my answer.
Thank you, Jonathan. My last question before we open it up to our attendees so that we could have a discussion, robust discussion around this is, and this is a question for all of my panelists, what recommendations would you give for the state of preparedness, for us to improve the state of preparedness to the next pandemic, particularly for those of African descent? So I'll first give that question to Dr. Fernandez de Silva, to Patricia.
I can never remember if I'm muted or not. Can you hear me?
Yeah.
Okay, great. And yeah, I mean, that is an absolute great question, right? Learning with our experiences. So the Global Health Security Index, it's a international group of health and security experts, and they rank countries' level of preparedness to respond to crisis in general. So they have just published a quite comprehensive actually report in 2019 where they rank the countries in terms of their preparedness, and they also present some specific recommendations. So there are several, but I mean, I can just highlight a few of them. So I'll start with a strong prevention system, right? So we're talking about your research, your immunization, your biosafety. That's those PPEs that we heard so much about, right? Masks, gloves, etc. Right? So then the second one is a strong detection system. So that means labs, your ability to test. Again, we all remember that, right? So then you have to have the ability to test, but you also need a strong epidemiology force. So there's the people that will actually make sense of the results of those tests and understand what they mean. Then you need a strong response system, right? You need to have emergency plans in place. You need to have the resources to implement those emergency plans and roll them out. You need to have a strong public health infrastructure to deal with that. And of course, you need an effective risk communication strategy. So the way that you communicate this to the public, it's very important because it has to be efficient. It has to be received in a way that is effective to curtail the problem that whichever problem you're facing. And just one more, which is, it's a really important one, which is a strong health system. So strong health system means the capacity of the hospitals, clinics, the health centers, healthcare workers. So we're talking about your nurses, your doctors, etc. But also, and just as importantly, I think all the panelists, we talked about it, ability for people to have access to quality healthcare, right? So it doesn't matter if you have all of this, if half of your population does not have access to not just health, quality healthcare that actually can take care of those issues. And of course, you know, like I said before, at UNFPA, we very much work with governments on strengthening some of those aspects of preparedness. But I also wanted to talk to you a little bit about how do we ensure, because the country can be prepared, but we realize now, right? Like Some countries, the wealthy, the more developed countries, they were better prepared. But again, a huge part of their population did not actually, was left behind. They're sort of, they fared the worst. How is this possible, right? So we need to prepare for that too, that the next time ensure that all of us will have the same type of response, the same type of treatment, the same type of access. And so in order to do that, we need to make sure that our communities are not disproportionately affected in emergency situations, including health emergencies like a pandemic, right? So the leadership really has to be intentional and purposeful in their efforts to ensure that all the communities are afforded the same rights, are given the same opportunities, and are able to actually play a meaningful role in the decision-making process that will eventually affect their lives, right? So, and at the global and at the local, both local and global level, comprehensive multi-sectoral strategies that focus on ending discrimination, including structural racism, like Jonathan has been talking about, right? And we're talking about what? We're talking about access to health, access to education, we're talking about employment, we're talking about access to justice, all these things that makes us a community. And of course, the removal of structural barriers to access to equity and equality in access to quality and affordable healthcare, because in terms of a pandemic, really that's sort of like the gist of the question, right? So basically, in short, remove the conditions that make people of African descent more vulnerable to contract the virus, and then remove the underlying reasons that make us more vulnerable to actually become seriously sick and die from the virus, right? And I think also my fellow panelists also touched a little bit about and talked about those. And I just want to end on something that is very important, which is a resource for everyone. Globally, there are many processes that focus specifically on ending racism and ending inequalities. For example, we must use the international community and those intergovernmental spaces, including the United Nations, to first highlight and visibilize the inequalities and the challenges faced by people of African descent, and then continue to work with these global communities for the fulfillment of commitments they have already made. They made these commitments to fight racism and to fight inequalities. In 20 years ago in Durban, a declaration was signed by 100 and something countries that committed that they would spend the next X number of years fighting racism around the globe. Just now in 2015, the Secretary General of the United Nations declared 2015 to 2024 the International Decade for People of African Descent, right? And now we are at the midterm of that decade. And so what has happened? What have we accomplished in these 5 years? What do we have to do for the next 5 years in order to actually to accelerate this fighting of racism and bring equity and inequality? I mean, at UNFPA, we are engaged in that work. We are actively working, of course, within our mandate, which is very much focused on women and girls and health and reproductive health. But collectively, we need to do more to accelerate the implementation of these commitments, all of these commitments, and specifically with a focus on ending inequalities and ending structural racism and bring more equity. Thank you.
Thank you, Dr. Fernandez da Silva. The question now I'm posing it to Dr. Joy. What recommendations would you give so that those of African descent within the region would be better prepared for the next pandemic?
Well, it's very difficult to say anything more after the answer just now. It was fantastic. I think one of the main things that we're going to have to focus on is the risk communication and the demystification of what it takes to first understand what the epidemic is. Remember, I told you that we're dealing with dengue fever as well. And so breaking down the statistics and what each person has to do. And it also is going to demand an understanding of what is fake, because there's a lot of fake news on the social media right now about all sorts of things. So we've already done that. How do you detect what is fake? And keep talking to the population. Also, this whole issue of sectoral preparedness, that level of sectoral preparedness, like what we have seen in the Caribbean, in the English-speaking Caribbean, I should say mainly, what we have seen in the English-speaking Caribbean is unprecedented. And I think a lot of that understanding by sectors is because of the leadership of the heads of government, both at the national and regional level. So everybody had to step up to the plate. The other thing that I think is going to be important is the linking of your specialist organizations, like how CARF is a specialist for public health, and your disaster preparedness organizations. So in the Caribbean, we had a core coordination group, CARFA, CDEMA, the Caribbean Disaster Emergency Management Agency, PAHO, and OECS, and we would meet regularly. It used to be every week, now it's every 2 weeks. And we would compare what we're doing and how we're collaborating. So having that link of the key are responding and the link to the at least regional, if not global, science. And I think it's also going to be very important for your leaders, not just your heads of government, but also leaders of large organizations, to have an affinity for the science, so that what is happening is scientifically based, what is promoted is scientifically based. We have been lucky in that regard, that the heads of government have listened to the science and taken advice. It has not always been the case. I can remember that there was a level of pushback for H1N1 that we're getting now. We're getting much more support for our recommendations. If we can keep that going, that will also help, because your citizens look for what the leaders not only say, but do. And so the actions of the leaders are imitated. I'm not talking only about heads of government. I am also talking about institutional leaders. So I can say ditto plus the risk communication and demystifying for everybody, so that everybody understands. If you do X, Y will happen. If you do Y, Z will happen, and so on and so forth.
Thank you, Dr. Joy. And the question, the same question now, I'm giving it to Jonathan in regards to the United States. What recommendation would you give to increase the state of preparedness for those of African descent within the United States?
So I want to go back to a very early, I think Dr. Joy, you mentioned this, environmentalism, environmental racism, because I think we could learn about what I think is our collectivity problem today. So for example, you have air above you and you have ground below you. And people who live in this block say, you know, I can't control the chimney 2 blocks away because I don't have ownership over the air above me. But the chimney produces smoke and polluting factors, and it crosses over. Today, we're in a country that has a collectivity problem. And if anything, we could see it in the environmental effects, environmental racism. In 1964, President Johnson gave a talk at University of Michigan, and he was coming kind of on the heels of President Kennedy when he said to the graduates of University of Michigan, in your time, we have the opportunity to not only move towards a rich society and powerful, but to a great society. And what was proposed after that was investments all across the country in what was seen as a challenge of urban decay, pollution, racial injustice, and economic dislocation. However, in my mind, since the 70s, the US has slowly been moving towards very isolated communities that don't relate to collectivity. And we've actually become more and more entrenched in our local, very spatial situations. Why is that important? COVID-19 is the smoke, right? Like COVID-19 is literally, there are no, spatial barriers. There are no, it just passes through. Because we think of ourselves not as a collective anymore, but as kind of an isolated, separate communities, we're not addressing this in the same way we're not addressing climate change. So the first thing really to do is to transform our collectivity back to a time when the government saw us as moving towards a great society. And we could do that at a very local level as well.
Thank you, Jonathan. Before we go, I understand that Dr. Fernandez, Patricia, I know that I think that there may be you may have like another meeting, another schedule. I'm just following up just to see whether or not if you could stay with us for the rest of the remainder of the class.
No, unfortunately, I'm actually already running late for my other commitment, so I very sadly have to leave, but it has been such a great conversation, so rich and so important at this time. And thank you so much for inviting us, for inviting UNFPA.
Okay, thank you. Thank you for joining and participating.
Of course.
Yes.
Bye.
I also would like to acknowledge and welcome another member in the room, our interim senior minister, Dr. Michael Livingston. So welcome.
Thank you. I'm sorry I couldn't join from the very beginning, but I've enjoyed what I've heard, and it's a pleasure to be here. And thank you all for doing this. Wonderful comments from our presenters. Thank you very much.
So now we're going to open it up for a Q&A from you, the attendees, and to have a discussion among us, with each other and also with our panelists as well. So if you have a question, please use the reaction button to, wave so that we could call on you, or do a gesture, or you could post it within the chat. Okay, do I see George? I believe I saw your hand go up. Do you have a question?
Well, I have an observation to make. I think the panelists were very, very well prepared, and they gave us a very good reflection as what's going on and what we should expect in the future. I'm particularly happy with Jonathan. He brought in this collectivity, the collectiveness. I think this is important. It's important because, one, even in the Bible, in the church, when Christ told his disciples and the Pharisees says to go in and make Christians, go all over the world and teach them Christians and make them Christians. Christ was saying he liked collectiveness. We don't just keep isolated religion. He wants isolated regions. He wanted his people, he wanted his disciples to go all over the world and make turn about Christian. That's what Mr. Jonathan was saying. Collectiveness is where we are able to form strength and able to move things. Say, for instance, like the example he gives, furnace, you say, oh, it's not in my building, it's in somebody else's building. I own here, so I'm not good. But nevertheless, its impact is on everybody. So in that sense, you cannot just isolate yourself. And we need to be able to come as a group, as a family, collectively, and work together. Even I've seen that, even with all of those things that we are going through, if all of us, Hispanic, African Americans, Caribbean Americans, Africans, we all get together, I think we can move there. But though we only move, we look at things that is not affecting me. As long as it's not affecting me, it's not affecting my family. And then it's not as important to me. We don't take it seriously. So I think I like the idea of this collectiveness. I think we need to always continue to work as a collective body. to be able to move things. No matter where you go, it's not just here, even in Africa, we don't have racial, but you have tribal, tribal conflict, which is even sometimes worse than this ethnicity, and it's worse than racial thing. And this is the same thing that goes on there. One tribe wants to take advantage of other, whether it's economically, socially, or otherwise. And this thing has gone on forever. The only way we can address these things, in a meaningful way, is to stand up, whether it's affecting the Hispanics or it's affecting Blacks. That is, we are all in this together, and we need to all work together. And I think more of that will be really good, especially now with this pandemic. It's not just affecting one person; it's affecting everybody. Right now in Sierra Leone, I'm helping with a funeral with an old lady that she's not I'm not family. We're not family, but my mother always told me to look after them when my mother passed. And this lady died early this Monday, and the family doesn't have anything. I'm doing all of those things. I could have just said, well, it's not my family member, so I'm not going to interfere. But all the funeral today, actually this evening, 6:30 their time, they're doing the 3-day ceremony. Everything we're doing, because we got to work as a community. We have to work as a group. We have to work collectively to be able to move things. As long we work separately, then it's a disaster and it won't do anything. And so I'm really, really grateful, and I am really impressed with the panelists today, all the activities. Just a comment.
Thank you, George. I do have a question, but my question is within also attendance is a professor of political science at Brooklyn College, Professor Nkomi. And before this segment on COVID-19 and public health, we were discussing structural inequalities within the world at large as to why is it that you would see those who are the most vulnerable on the continent, in the United States, in the Caribbean, in Latin America, why those are the most vulnerable are affected, and the structural dynamics at play that will, that makes these particular conditions possible. My question is for Professor Nkomi, and I know that you have your hand up, so I suppose you have a question as well. Professor Nkomi, can you speak to the structural
barriers?
Yes.
Okay, thank you very much. Well, the world we live in has been shaped by imperialism. And the people who are said to have discovered the world, even though the world was there, but they were clueless. They found out that how clueless they were. As a result of that, we have international law. And we all respect international law, but international law legitimizes the seizure and forced appropriation of people, land, and the wealth that those people and land were able to produce. It did that as a worldwide kind of phenomenon. So when we see poverty and wealth in the world today as, regional characteristics, those who were able to plunder are the ones that are wealthy. Those who were plundered are the ones that are poor. And then within those systems, you also have poor and wealthy. And if you're connected to the powerful interests, you're going to be wealthy. So, we all benefit from it, or we are disadvantaged by it. So when we see, for example, the richest continent in the world is Africa, in terms of the natural resources that it has. But those resources are not controlled by Africans. It's not even controlled by the corrupt governments in African countries. And, that ownership structure has been legitimized as appropriate, acceptable, and legal. So it has repercussions on the health outcomes. It has repercussions on who gets to to be treated as though they are geniuses and who gets treated as if they know nothing. And, you know, this power structure, I think, is what we need to decenter or disrupt, because it caused a lot of, all these things we're seeing with COVID were there, but you don't see problems as clearly in good times. It's during times of crisis that we see problems more clearly. So for me, this is an opportunity for us to say, okay, now we know. And statistics are being gathered, and there's evidence and analysis, and we can do something about it. And there are promises also that powerful countries have made on what they are going to do in equity for people of African descent. You know, there's also the Sustainable Development Goals. So I think that we all should take an interest in world politics. You know, so the UN is here in New York. We can interact with the UN and ask for justice for all people. Because if we help the most disadvantaged, we are all going to be helped, you know. So.
Thank you, Professor Nkomi. I think we have time for one more question. I know that Dr. St. Joy has to actually leave soon. So just the one more question, then afterwards, we'll wrap this up. Okay, Mr. Nkomi.
Good evening to the panel and to attendees. Dr. Joy did say an important thing about collectivity, and I'd like to look at it from the point of view that even though this is a panel dealing with people of African descent, yet since we don't live in isolation, whatever happens in the US also happens to affect other parts of the world. Dr. Sanjoy mentioned that the powers that be or those that are in power need to be part of this collective. And I would want to say that is very true with regards to the United States, where the head is not in touch with reality. So what do you expect from some of the population? And then a second part is, do we have anything to say about the AU as far as the diaspora and the effects of COVID-19 would be?
Thank you.
Can I start with the second part? The African, when you say AU, you mean the African Union?
That's correct.
Okay, so in my presentation, I would have spoken about the intervention of Dr. Tedros, the Director General of WHO, to allow the CARICOM countries and also CARFA to have access to the African Medical Supplies Platform. Because I told you that seizing, and subsequently we have bypassed that particular market. But the access of small countries like countries of the Caribbean has been hampered not just by the supply chain issues that occurred, but also because we're small. If you have a country with millions ordering supplies, you're going to supply that country and not necessarily a country with less than 300,000 people like Barbados has, or less than 40,000 people. And so having that access to the African Medical Supplies Platform has assisted us. In fact, CARFA is looking at the availability of certain supplies. The other thing that has happened in some of the countries is that in the same way that we had issues with supplies, we had issues with not having enough specially trained personnel. So for example, in Barbados, there was a program where we got nurses from Ghana. We have also gone to Cuba for some of that surge capacity. A lot of the countries in the Caribbean also got surge capacity from Cuba. But we were speaking about the African Union. And as well, CARICOM, the CARICOM Secretariat has also made an outreach to the African continent. The chair of the first 6 months of 2020 also visited, and there are CARICOM missions being opened in certain countries. So the African Union, through Dr. Tedros, and also through the diplomatic outreach of the CARICOM Secretariat, CARICOM being the political and convening power that has largely brought the region through this pandemic. We've reached out to the African Union and they have assisted. Now, the first part, this whole issue of regionalism, and we've used it, I think, to our benefit in the CARICOM region, but this issue of regionalism and multilateralism is the only way that we're going to get out of the pandemic alive. I'm coming shortly.
Yes, he want to carry control money like he's in trouble.
Oh, okay. Okay. Sorry about that. It's the only way that the world is going to get out of COVID-19. Selfish maneuvers are not going to help the countries that are pulling the selfish maneuvers. Even them, they will not come out of this in the long run. COVID is something that we've got to pull together and try to fight. So I'm hoping that the feeling of regionalism and multilateralism will spread more than it has. I do not like the fact that the vaccines and treatments that seem to be working, because we've just had another one proven that it is not effective. I do not like the fact that some countries seem to be hoarding these things. Those countries have to fly around the world. And if only they are vaccinated and not the countries that they come to, there will be issues, there will be spread. So this whole issue of global governance and ensuring that there is cooperation across the world, that's the only thing that's going to save us. It doesn't seem that the idea has penetrated too deeply yet, but I hope it will soon. I think I have to go now. That was my husband asking me questions. So when your husband is asking you questions, you need to leave.
Thank you, Dr. St. John.
Thank you.
Bye-bye.
Yemi, you're muted.
Yemi, you're on mute.
I am on mute. I didn't realize that. Sorry about that. This concludes our segment of COVID-19. I would like to thank our esteemed panelists for coming today to share their knowledge and their insights as well. I also like to thank you, the audience, for attending this segment. And also to let you know that this is only one segment in a 4-part series. So the next segment on the gendered effects of COVID-19 is next Sunday. So I would like if perhaps Dr. Reverend Van Hook, or Reverend Livingston, if you could pray us out to end this segment. I know that you wasn't expecting that, Reverend Livingston, so it's okay. I don't want to put you on the spot.
I was just referring to Reverend Van Hook.
He gave the opening prayer.
Reverend Van Hook was the one that brought us in. Dr. Reverend Livingston will lead us out.
All right, I'll do that.
Okay.
Yes. God, we thank you for calling us together and reminding us that we are together, one world, one people. That does not mean we don't appreciate the very distinctiveness with which you created your people. We celebrate our regions of the world, our our colors, our languages, our faith. But deeper than that, beyond all of that, we are one people, and what affects one of us in one country affects another. And we are seeing that in this pandemic. And so we thank you for people who bring their expertise and their knowledge and their passion for wholeness and healing to this conversation today. And we thank you for the time that we've spent together. May we learn from this experience and the others that will follow, so that together we may find our way, work our way cooperatively together toward wholeness and healing. We thank the African Fellowship for its effort to organize this experience, and we look forward to further conversation. We pray in the name of our one God, now and forever. Amen.
Amen.
Amen. Thank you.